This one is for all you smart and savvy, amazing clinicians out there. Strong foundations in biomechanics and clinical reasoning, of course, is going to sharpen your efficiency and sequencing for your initial evaluations. So as a brief little example, when a patient shows up, for instance, with a limitation in cervical rotation, I will look where that restriction shows up in that arc of motion. So let's say the limitation appears early on, like within the first half of the rotation, and we're getting a firm end feel on that. What I'll do is I'll prioritize the cervical flexion rotation test. Now, why am I thinking that? So we know that the upper cervical region, that C1, C2, contributes the largest share of rotation cumulatively for the cervical spine. So when that block shows up early, I'm looking there first. Moving forward, if that limitation kind of happens or pain shows up more mid to end range, that's when I'm kind of reaching for that cervicothoracic differentiation test, because by that point, the lower cervical spine and the thoracic segments are playing a bigger role. So I want to see if the T-spine is influencing the bigger picture here as it relates to a limitation in cervical range of motion for rotation. So the point here isn't to do every sort of test and kind of throw darts in the wind here. It's to let biomechanics and clinical reasoning clarify and prompt the remainder of the evaluation and the plan moving forward.